Welcome everybody to the Global Digital Health Network's June monthly meeting. We will get started in just a few minutes. We'll just give everybody a few minutes to join, but we're really excited that you're here with us today and are very much looking forward to our presentation, our panel today. So please stay tuned and feel free to introduce yourself in the chat. Hi, everybody. Welcome to the Global Digital Health Network monthly meeting. We are just letting everybody join and get settled, but we'll get started in about 2 minutes. Please feel free to introduce yourself in the chat and let us know where you're calling in from. And we're very much looking forward to engaging with you and the panel. All right, I think that hopefully most people who are going to join have joined, and I'm sure a few more will be joining us as we go on. But good morning, good evening, good afternoon. Welcome to the June Global Digital Health Network monthly meeting. I'm really excited for our session today. My name is Christina Valella. I am one of the co-chairs of the Global Digital Health Network. I'm joined by my other co-chair, Olivia Velez, who's here on screen. And we're really excited for today's meeting hosted by one of our advisory council members, JSI, and specifically really excited for the conversation that the presenters are going to have today around data and enabling the health supply chain and really optimizing it, especially in the face of our recent or our ongoing pandemic. So with that, I would like to turn it over to our moderator today, Edward Wilson. Edward is a director for the Center for Health Logistics and the Partnership for Supply Chain Management at JSI. And as the director of JSI's supply chain practices, the Center for Logistics and Partnership for Supply Chain Management, Edward oversees over 30 projects that are improving access to medicines and diagnostics in low and middle income countries for multilateral, bilateral, private sector, and philanthropic clients. And Edward has been with JSI since 1986 and has over 30 years of experience in pharmaceutical supply chain management. So I'm going to turn it over to Edward, who will be facilitating the rest of the meeting. And thank you again in advance to our panelists, and looking forward to an engaging session.
Great. Thanks so much, Christina. I appreciate that. And welcome everyone, and thank you for taking the time to be with us here today. I'm really excited about what we're going to hear from our panelists. So let me just start with a quick overview of our topic. The holy grail of almost all supply chains is to get data directly from customers to better enable end-to-end supply chain operations. Data and digitization are core to serving clients in supply chain transformation. And as this last year has reminded us, data about client demand as well as supply are essential for a resilient supply chain. In this session, we're going to focus on the central role of data and digitization in next generation health supply chains. We'll feature examples from 4 systems in 3 countries that demonstrate leadership and lessons learned in enhancing data visibility and use through digital solutions. These solutions have improved performance and increased transparency and accountability along the value chain. We have 3 distinguished panelists who will share their experiences with us today. And they are Harrison Mariki, who is a senior advisor within Supply Health in Tanzania. Harrison has worked in supply chain management for nearly 9 years, building the capacity of people and systems, supporting public health supply chains in Tanzania. He started his career providing technical support to the medical stores department in Tanzania in inventory management of HIV/AIDS, malaria, family planning, TB, and leprosy commodities as a supply chain monitoring advisor. Harrison has extensive field experience as part of the logistics management unit, where his role was to strengthen data collection, integrity, and use at service delivery points for logistics decisions through implementation of innovative solutions like the Electronic Logistics Management Information System and the ILS Gateway. He's also participated in the quantification of commodities for HIV programs and in the design of logistics systems. Our next panelist is Mercy Lutukai. She is an advisor within Supply Health in Kenya. Mercy is a public health professional with 12 years of experience designing, initiating, implementing, and managing and leading health programs in both emergency and development contexts in Africa. Her experience spans different public health work streams and interactions, providing technical assistance to communities, subnational, national, and regional levels on health and WASH issues. Mercy's area of expertise include health system strengthening initiatives, monitoring, evaluation, accountability, and learning, public health supply chain management, integrated disease surveillance and outbreak response, expanded program for immunization, advocacy, communication, and social mobilization, public-private partnerships management, curriculum development, and capacity building. And last but not least, Al Shiferaw. Al is JSI's Deputy Director, Deputy Chief of Party and Technical Director for the USAID Ethiopia Digital Health Activity, which is the primary digital health project funded by USAID to assist the Ethiopian government in its digital transformation of the health sector. Al brings decades of diverse private sector and international development experience, having first worked for large multinationals in the US, as well as leveraging technology as a tool for global development over the past decade. His private sector experience includes a range of Fortune 100 companies such as 3M, American Express, and Wells Fargo. Al is also the principal representative for JSI's technology teams in Ethiopia, providing projects with overall guidance for aspects of digital health. These are our panelists today, and I very much look forward to hearing from them. So today's webinar, we're going to use a question and answer approach, so there won't be any PowerPoints, and then we will respond to questions from those of you in the audience. I encourage all of you to submit questions via the Q&A function as we go along, and we'll respond to them once we have finished the rounds of questions with the panelists. Great, so let's get started. So as most of you probably know, the holy grail of almost all supply chains is to get demand data directly from customers to better enable end-to-end supply chain operations. In Kenya, the government is collecting supply and demand data at the community level and transmitting those data into the National Health Information System for use. So Mercy, can you explain to us what problem you were originally trying to solve and how you did it? And then maybe talk a little bit about the results that you've seen so far.
Thank you very much, Edward. This is quite an interesting topic for us. As we all know, community health programs have a central role in achieving the sustainable development. However, the community health programs globally are often hindered by very poor availability of health commodities. And this is especially within the low middle income countries like Kenya. For instance, in Kenya currently, a quarter of the reported deaths per year are attributed to preventable diseases. And over 7 million children under 5 years of age lose their lives each year, mainly due to treatable and preventable conditions. And this is a narrative that can be changed by the community health volunteers, bringing them and ensuring them that they have commodities and that the different system actors at all levels are able to access community health supply chain data and visibility at that level. In Supply Health, an affiliate of the JSI in East Africa, with presence in Kenya and Tanzania, is on that journey of transforming lives by co-creating innovative and sustainable solutions for health communities. And in 2017, In Supply Health partnered with the Ministry of Health in Kenya to establish an approach known as the CSTOC approach. CSTOC approach is a combination of the mobile technology that supports demand-based resupply procedures and connect the community health volunteers to their resupply facilities. The approach is complemented by user-friendly dashboards that enhance visibility and accountability of the data coming from that community level, as well as a people-centered approach to encourage and to train and to motivate the system actors in resolving their challenges, ensuring that root cause analysis, action planning, and problem solving is done collaboratively. And with this approach, you are able to start off in Siaya, one of the counties in Kenya, which is more developed and has about 3,000 community health volunteers or over. We began in this county with about 800 community health volunteers to establish use of this CSTOC approach for reporting of commodities at the community level. To note is that in this approach, we do not buy phones for community health volunteers. We use the phones that community health volunteers have, and that the system can be used either on feature phones or Android phones. We started off at that level, piloting it, and moved to ensuring that not just community health volunteers within the developed context can report, but also community health volunteers who are illiterate or of low literacy level and within hard to reach areas that have low connectivity can also report. So we extended this approach within 4 other counties in Kenya, the arid, semi-arid regions of Kenya along the borders of Kenya and Somalia or Ethiopia. And we focused also looking at pastoralists or nomadic communities to be able to report on this. we have seen significant changes within the reporting. Number one is that our reporting rates or the visibility of the data within these hard-to-reach communities as well as within the developed context has risen. Initially, there was no visibility of community health supply chains in the country because there was no tool at that community level to provide data on the community health supply chains. And reporting rates are about 80% currently. And this is not just around the reporting, but also the use of that data to facilitate availability of commodities to the communities. Understanding also of these communities has been brought about by the fact that we integrated an approach called human-centered design approach that interconnects or brings the end user at the design table to ensure that the process as well as the solution that we are presenting to the country and to this community fits within their needs as well as stands a chance for sustainability. Thank you. Sorry, Edward, we cannot hear you. You're on mute.
All right, thanks so much, Mercy. Really appreciate it. Really interesting to see how we can get data all the way from the community level and really help them use those data for their own resupply and product availability efforts. That's terrific. Can you just say a little bit about how you talked about human-centered design, but obviously critically is making sure that you have local stakeholders and Ministry of Health really bought in and committed to this process. Could you say a little bit about how you made sure that happened?
The human-centered design ensured that we have a better understanding of our end users and that we are not developing a solution for ourselves, but a solution for them that can be able to resolve their challenges. So what we did is we took on the ground to do what we call a usability testing and also looking at the context or dynamics that influence the community health supply chain. By doing so, we were able to redesign our CSTOC to fit into their needs. Initially, the CSTOC could be reported using the smartphones within one of the developed contexts, the initial county that we began with. But within these areas, smartphones were not a thing with the community health volunteers. They were using feature phones. And remember that the community health volunteers we were targeting were of low literacy in contexts where there is poor connectivity as well as internet availability within these areas. With that in mind, we were able to redesign the CSTOC to facilitate the needs of the community health volunteers as well as their supervisors. Number one is the manual inventory card of the CSTOC we were able to have icons that could be identified by low literate community health volunteers to report. Another thing is within the CSTOC approach or the CSTOC tool, we were able to redesign it to also have an aspect of CHAR functionality where the CHAR or the community health assistant or supervisor to the community health volunteer could be able to redirect or support the community health volunteers in the reporting process. We were also able to have an overvoice to it for the community health volunteer to understand the instructions around reporting. And because of this human-centered design approach, we are also able to identify other aspects that touch on the community health supply chain, issues around commodity availability, issues around decision-making, issues around community acceptance of community health volunteers to provide commodities at their household level. It provided a long list of insights that were even beyond the community health supply chain aspect, but affecting the implementation of the community health strategy.
Great. Thanks so much, Mercy. Really interesting. So moving along, as we digitize more and more of our operations, we increasingly find that business processes span more than one function, department, or ministry. To really improve performance, increase usage, and improve collaboration across systems, you have to refine and digitize complex processes that cut across entities, which is exactly what Ethiopia has done with its medicines registration, import, and approval processes. So Al, maybe you could explain to us a little bit kind of what problem you were trying to solve, how you did it, and then what are some of the results you've achieved so far?
Right. Thank you, Edward, and thank you also for GDH and for the invite. So happy to share the experience from Ethiopia, and happy follow to from Mercy, who just talked about the supply chain activities that we see at the community level. So let me talk about the Ethiopia experience, where we started about 10 years ago, focusing on the central medical stores as well as the regional central medical stores, what we call hubs in Ethiopia, that allowed us to get a lot of visibility into supply chain. From that perspective, the country has a huge, massive amount of information that we can drill down and get a great deal of insight of supply chain activities over the last maybe 6 or 7 years, and that has been great. We also did some work on the facility level, focusing primarily on high volume facilities. So as the case in most African countries or maybe elsewhere as well, about 80% of the patients tend to get service from a small number of facilities. So in our case, we've been able to automate the store management system in about 1,000 of the facilities. And again, there we're seeing a great deal of information. So starting from the very top to the regional levels, and then going one step below to the hospital and health center level, we've got a great deal of visibility. So at the third level, when you come to the patient information, where it's sort of the patient meets the pharmaceutical contact, that is work we're starting to do in the last 3 years or so. We're helping improve the business process and also automating and digitizing that aspect as well. But that is going to be a much more extended effort. That's going to take some time. But as it stands today in Ethiopia, we do have a great deal of information, as I said, of what's available at the central level, what's available at the regional level, and what's also available, at least from the facility perspective, at each of the store information at hospitals and health centers throughout the country. Now, having said this, I mentioned at the start that we did this work over a span of about 10 years, and a great deal of effort by the Ethiopian government and partners who did this work. But about 4 years ago, we started to realize that there are a lot of challenges in terms of getting accurate information and confidence levels in terms of the precision of information that we can use for decision making. And I kind of talked about the 3 levels: the center level, the facility level, and then the dispensary level. But we realized there's sort of a step 0, and that is the regulatory piece. And what we quickly learned is if you don't get your upstream right, you're not going to be able to get your downstream right. And by that, basically information that you have to capture from the point of procurement decision, from the point of products coming into your country in the port level. So we tend to think of supply chain more or less when products arrive at the central medical store level, but then we've extended that horizon to say that we believe supply chain happens at a much, much earlier phase. So what we've done over the last 2 years or so is to help the Ethiopian Food and Drug Administration automate the process from the perspective of registering products from import permit process, the pre-shipment, and then up and coming, I'll talk towards the end on the port clearance side. Now back to your question, I've set the background, Edward. So what does this mean? So when you think of your supply chain perspective only from the CMS level down to the hospital level, you're still living within the space of the health sector. But the moment you start to expand that perspective, you realize that there are actually other players outside the health sector. So in our case, we've identified that we had to work with the Ethiopian Customs Authority because obviously products do not hit the health system before they actually hit the Ministry of Revenue / the Customs Authority. And we saw this as actually a very positive because systems work better when they're interconnected. So in our case, we took the individual products I talked about earlier at the CMS, at the store level, and then coming up now at the dispensary level, and putting them together into one big system and integrating that further into another agency. So what this has meant is that we now have a lot more greater visibility, but not just greater visibility, but assurance and high level of confidence of what's coming to the country. So not only we know what's available in the public central medical store, but we now have information of what's coming from the private sector, the international organizations such as UNICEF, USAID, or any other agencies, because they have to go through the system. So the lessons in Ethiopia has been that supply chain is very broad. Obviously, a great part of it lives within the health system space, but we also have to work with other agencies that play an active role in the importation of the medicine, and then allowing us to have a much more accurate information, such as building a much more accurate national product catalog that becomes this sort of the single source of truth as we push commodities down the road, and along the way we collect information that we present in dashboards and so on. So the information that my colleague Mercy mentioned could be best supported when you've got your upstream working properly and having proper information systems at each of the levels. Stop there.
Great, thanks so much, Al. Really interesting. And I know there have been some fairly significant improvements in the sort of import approval process as a result of this. I wonder if you could just say a little bit about some of the kind of tangible results in terms of speed with which the import is now moving.
So the import permit process 4 years ago was all manual, right? And that was one of the reasons that products were not arriving in country on time. So essentially, if you can imagine, the product delivery to Ethiopia was not visible until the product physically arrived. And that's a span of about 3 to 6 months, sometimes a year long process in the procurement system. But with automation, we've been able to reduce that to a couple of days. But what we've now done with the integration with the Customs Authority, what's kind of broadly referred to as the single window, because of the automation that we provided, importers now get an automatic approval, provided that they have an active registration, market authorization of the medicines, and that the product, there's no hold on the product from the government of Ethiopia. So if they've been flagged for not being allowed to import it, then we automatically get a rejection. So we're now down to like a matter of seconds for importers to be able to get the necessary documentation. And one thing to add, guys, not only an approval, but actually once you get the import permit process, you know for sure that once your product hits the customs, lands in Ethiopia, you're not going to have this bureaucratic process for it to clear through customs. So it's been such a big win for the country in terms of being able to collect information, but it's also been a win for the importers, starting with the government and other agencies, and having this confidence that they have to spend less money and time in processing their clearance.
Great, thanks so much, Alan. I think for any of us that have struggled with importing pharmaceuticals into countries, that this is just a huge step forward and one of the really tangible benefits of the excellent work that you and all of the government of Ethiopia have been doing in this regard. Terrific. So improving data visibility and digitizing processes are critical, as we've just heard from Mercy and Al, but using the data that we collect in more proactive ways to manage our supply chains and programs is even more critical. And so for this, we have a couple of examples from Tanzania, one focused on the use of machine learning and the other on the use of temperature monitoring data. So Harrison, maybe we could start with the machine learning playbook. And can you talk to us a little bit about the problem you were trying to solve and how you did it and what sorts of results you've seen so far?
Hi, Edward, and the rest of the team. So I'm looking at the chat and I can see like we have a very good group, and thank you everyone for participating. And I enjoyed very much the conversation from Mercy about the community level, and Al on how also we need also to think of making sure that the upstream is visible even to the players on the ground. And so for Tanzania, we are also learning a lot the importance of digitizing and using the data to be more predictive and more proactive. And for the past year, what we have been seeing is that there's been some thinking around using artificial intelligence and machine learning to try to harvest the data that we collect from these different systems into being more proactive instead of reactive. And so as you get we wanted to be very systematic about this so that we can really see the benefit of such technology if we decide to adapt it. So the machine learning playbook was a way of getting clarity and certainty of how you would integrate machine learning into existing information systems. So it's a playbook, it's a tool, it's a guide that can help you to integrate these technologies into existing supply chain systems. And the approach that we used was mainly to involve as the different stakeholders the different supply chain stakeholders. So we looked at the private sector, the government themselves as the driver and owner of the public health supply chains. We spoke with academia, we spoke with AI solution providers, both local, and we had partnership with Macro Eyes, another global machine learning technology company, who we've worked with in other programs as well, so that we could get a lot of consultation behind this playbook. And I am very happy to see that we now have it ready. And within this, so what we have a deck, which is more of the tool that describes both the theory of change. So what you need to have in place, like the different preconditions that you need to have in place to ensure that from the beginning you are thinking about integration, because there are already systems that are there. You are thinking about scalability of the solution once you decide to go full scale, and also you are thinking around sustainability of the solution. And this is very important because it's new. The skills that are needed also may be different. How there are issues about regulations that you need to think about, ownership and security of the data. Those are the things that they kept coming up with as we were discussing the different stakeholders, especially the Ministry of Health. So some of the successes that I can talk about that is and the uniqueness of the playbook is how consultative it was to get it done. The other thing that I want to talk about now was also like we've spoken about getting the data from the community level, the upstream, but something also that we can do these days with the technology that we have with the Internet of Things is you actually can get data from machines themselves. So we introduced remote temperature monitoring devices to monitor the cold chain for the immunization supply chain in Tanzania, and we've currently it's in more than 4,000 health facilities. That is almost 60% of the country already using the devices. So at the beginning, when we're introducing the technology with our partners, NextLeaf and the government, we were thinking around, okay, so you have this new technology. How does it fit into the existing LMIS? How would you integrate it? Do you want and it had a dashboard of its own. So we were thinking around how do you leverage the existing data use structures, the existing data collection structures, so that you can quickly get people on board with this new tool, with the new insights that are coming in. And also because the LMIS, as you know, it's a routine collection of aggregated data that you do maybe on monthly or quarterly basis. But this is data now that you have access to, which is on real time. So how do you make sure that people are looking at that more regularly and more routinely and also more proactively? Because with cold chain, you don't want for the alarms to hit. You want to predict before the alarms start coming in. And you need to pre-plan and make sure that you have resources allocated, for instance, to be able to take action in case maybe there is a breakdown in the cold chain. You need already to plan for the resources to be there. You don't want for the cold chain to break and then start planning for resources. That we've seen something that is is a challenge. So we wanted to be able to figure out how we would integrate that into the existing systems. And we ended up with a very simple solution of just using a single sign-on, where a user with existing login credentials to our LMIS will be able to also access the RTM data. And we introduced the links to the different aspects of the coaching in the different parts of the existing LMIS where it made sense. So when you are looking at your stock status, you can also check, click on the link, and it will take you to the dashboard where you can also see how those vaccines are stored as well. So that is something also that we consider successful. And I think now that the country is also thinking around introducing the new vaccines, so we are at least better set off to be able to monitor these new vaccines, which we know have a shorter shelf life and some without even PVM. So you really need to be able to monitor the cold chain, especially for COVID vaccines in real time. So that is something that we consider success. Thank you.
Thanks very much, Harrison. Really interesting, new technologies, whether it's machine learning technology or remote temperature monitoring technology, really thinking about how you integrate those with existing systems and processes and people to be able to extract the most value out of them and to add the most value to system operations. Super important, because I think sometimes we get distracted by the shiny and forget to figure out how it's going to actually work with the people and processes we have. Could you say anything about the results you've seen so far from the RTM activities in particular? Have you seen a difference in the way managers respond? Have you seen a difference in terms of actually excursions or expiries that you could talk about?
Yeah. So before, when we were using paperwork, what we learned first of all was we learned first of all that the data we were initially collecting through the paper forms was not correct. That was the first thing that we learned, because we noticed that the cold chain alarms were so many, and even the users will usually even say, maybe this is not my data. But over time, what we have seen is the decision makers have been following up and making sure that the alarms are being dealt with, and we've seen improvements. And now there's more trust in the data, even for the user themselves, and also the culture into using the data more frequently has improved. You can I'm, for instance, in many WhatsApp groups that are connected with the immunization managers, and I can see how every now and then you can see people following up. So that's been a very, very positive, positive aspect that we've seen from the remote temperaturing monitoring devices. So the big thing is how people are now taking action, and also it helps in root cause analysis. Like you can see people calling to find out exactly why there is an issue. And also we have seen that it's driving innovation. You can see people making videos, for instance, explaining on how you would adjust the temperature, and sharing that to others, and quickly getting those lessons to the lower levels where we see that there are challenges in skills, and that has really helped.
Great, thanks so much. Thanks so much for that. Great example of how important it is to actually use the data that are coming up through these systems, that if you don't start using it, people don't have trust in it, and then they're not actually using it for effective decision making. That's terrific. So let's, again, if any of you have questions that you would like to direct to the panelists, please enter them in the Q&A section of the Zoom, and we'll respond to those after the panelists get done answering the sort of canned questions that we have. We have one in there already, which is great. So let me now turn to asking a second round of questions to all of our panelists, and this is going to be the same for each one of them. Obviously, what you've done is really exciting and sounds like it's been quite successful, but of course we know that I'm sure it didn't go perfectly. So perhaps what challenges did you face along the way, and then what did you do to address them? If you could just briefly talk about that. So let's start with Mercy and C-Stock.
Thank you, Edward. Yes, it was a bumpy ride, but that I would say that we have stabilized. And just to reflect back is that Systock in itself is not just about a mobile technology or solution towards demand resupply procedures, but also incorporates two approaches: the impact teams approach, which is a data quality improvement approach that is people-centered, bringing multidisciplinary teams together to resolve collectively their problems around supply chain, and also the user-friendly dashboards. And these dashboards are viewed both by the community health assistant, who is the supervisor of the community health volunteer, as well as within the system actors at the district level and at the national level. So one of the key challenges that we identified is at the start of the project, we had in mind the sustainability front or aspect to it, where we were looking at community health volunteers using their own funds. However, in these districts or sub-counties that we are working in, we already had partners who had gone forward and were also providing mHealth solutions, and they were buying the funds or had previously purchased funds for the community health volunteers. So there was an expectation by the community health volunteers as well as the system actors that they should be provided for funds to be able to do the reporting. Then there was also the other challenge that initially we had the Systock, which is a solution that can be on the USSD or on the app, initially being on the app, and we needed to transition that to a USSD. And this meant that we also needed to understand the challenges of low literate community health volunteers, as well as facilitate them to be able to report within their context. So the approaches we used to do this is, number one, the human-centered design approach. The human-centered design approach helped us to dive further to understand the practical barriers around the implementation of the Systock. Number one, as a technology, as well as in terms of data quality improvement. We were also able to do a usability testing, which is under the human-centered design, to understand what challenges would the community health volunteers face while reporting using their phones, their specific phones. It was very interesting to learn that they would actually, in spite of being illiterate or not able to understand the figures, they still could be able to report using their phones. We have in Kenya an M-Pesa, what we call a money mobile system that they understood. And so they were able, based on that knowledge, for us to structure our training for them to be able to report using the mobile phones. Another thing is, while we are doing the usability testing, remember these are low settings with poor internet connectivity. And yet our Systock also relied on the connectivity or the internet availability of it, and the electricity, of course, for the phones to be charged. So these are some of the areas that we are able to realize, and through the human-centered design, came up with an offline system that could be able to facilitate community health volunteers to report. I think for me, the human-centered design was the biggest entry point to resolving the challenges around ensuring sustainability and use of the Systock within these low settings. Thank you.
Great. Thanks so much, Mercy. Really interesting. Al, over to you. Maybe you could tell us a little bit about some of the challenges you faced and what you did to resolve them.
Right. Thank you, Edward. All right. So there are a number of them, but I kind of picked 3 or 4 in the hope that the audience might be interested in this. So one thing reflecting back is that, oftentimes when we think about solutions to a problem, we often think about products. So kind of equating solutions to a single sort of siloed system. So for a hospital, we might think of an image management system. For CMSs, we might think of an ERP and so on, right? But what we've learned is a lot of times the solutions have to come from a number of products. And in that case, it has to be a system. So having to explain the difference between what is a product versus a system is always a very tricky way. So when we thought about putting together what I described top of the session in terms of being able to build that interconnection between the different levels. And in our case, it was a bit more complicated because not only we're talking about linking products together to build a system, we're talking about actually making a connection from one system to another system. And then I'll add one more to it, which is connecting one system from one agency to another system that's a completely different agency. So the communication and then securing the buy-in to be able to do this was a little complex. We had to sit down and think a lot about it. And in our case, we had a very high-level government support that was able to bring everybody together and being able to provide trust for us to be able to do this work. And there was goodwill on both sides, but that step needed to be secured. You just cannot start the technical process before ensuring that you have done that. So it was one of the challenges that was quickly resolved, but it still remains to be an issue that others have to do if they were to do what we have tried here. The other issue is helping people understand that your system is stronger when it's actually connected to another system. So that means you have to create some type of interdependency, and that can scare people. But the bottom line is that sort of the concept of we're stronger together, right? So I think that rule also applies to products and systems. So in our case, we are now seeing the benefit of the Ethiopian Food and Drug Administration that comes down to the Ethiopian Central Medical Store, what we know as EFSA, will perform better or are performing better as a result of this interconnection, or you want to call it interdependency. So that was another thing that we have to sell and help understand. So we're not just going to say, this is how it's going to work, but we have to go and sell the value before this work started. So that is on the process and the system side. And then the other two I would add is, no matter what though, even though you have this connection that you've done and you know that the hooks that you built are going to be pretty solid, it would still be naive to believe that somehow someone is not going to go around that or sidestep the process. So with that, we had to ensure that there's a very strong government buy-in for monitoring as well as enforcement, because without it, the system alone is not going to self-police itself. So that was a huge lessons learned, and we were able to secure that strong commitment from the different agencies that we working with. Again, another step that could be side steps. The last but not least is when you start to work across agencies, you have to start to work across different sort of languages and variables. I'm trying to keep this very generic. So the product list that you may have within one agency is not going to be very similar to the product list that, say, the customs agency will look at. So that required a lot of sitting down and working together. You want to maintain the different systems as they are, but you want to be able to have them talk to each other. So we built a number of systems around that, and that took some time. But at the end, I think everything has worked out, and we continue to closely monitor and support the system.
Great, thanks so much, Al. I think just as we saw with Mercy, the importance of really kind of meeting people where they are, getting their commitment and buy-in to the value of what you of the system and the processes that you're putting in place, and then getting commitment and buy-in to really enforcing the use of those systems as well, and developing a common language that people can use together to make sure the systems are working well. Terrific, thanks so much. Harrison, tell us a little bit about some of the challenges you faced and the solutions you found.
Thank you, Edward. So maybe with the playbook, mainly the challenge was because we are developing the playbook around when the COVID just started, and so what we had planned in terms maybe of the workshop, those consultative workshops, we had to quickly change because physical meetings were not possible. So we had to start going doing virtual, and also like change the approach. Maybe instead of doing group interviews, maybe meetings of smaller groups or doing individual interviews. So we had to change that approach quickly, and we were just starting, and not everyone was ready used to virtual, but we are glad that was successful. And I'm glad even today we are all used to maybe a webinar like this, which would have been physical. And with the remote temperature monitoring devices, what I remember as a challenge is the remote devices use mobile lines. And so there was a change of how you register those mobile lines in Tanzania. So we had to use those national ID came up maybe 2 years ago. So we had again, so the lines were registered, we had to change them, especially towards the end of the project, which affected a bit the data transfer and completeness of data in the system. But now that is picking up again. So if I had to go back, maybe I would wish I would have been able to anticipate COVID and anticipate the government changing the registration process. Yeah.
Yeah, that's right. The importance of flexibility in being able to adjust your approach based on the environmental circumstances and ever-changing needs. Yes, critical. It's critical. All right, so we have about 10 minutes left, and we do have several questions in the Q&A. So let's move over to some of those questions, and I will just sort of quickly go from top to bottom. And some of these are general that any of the panelists could answer, and some of them are specific to individual examples. So the first was, somebody asked, what's the root cause of global health and pharmaceutical industry supply chain challenges in low and middle income countries? So that could be the topic of a several-day seminar. But do any of our panelists want to just offer a quick reflection on that based on your experience?
I can give it a shot. In my own experience, it is a lack of data and data to use, or ability even to use that data to make informed decisions or implement them specific to those contexts. A good example is when we are implementing the SysTalk approach, one of the things we realize is you will find that the community is stocked out, but the national level or the higher level, the district or county level, is overstocked. So this means that data is not easily accessed or visible to be able to ensure distribution and redistribution within these different levels. And as we interact within the impact teams approach, which I mentioned is a people-centered multidisciplinary approach that looks at root cause analysis, action planning, and follow through of those actions to ensure supply chain performance improvement, we note that there is also a challenge in the capacity of the staff or supply chain staff to do an detailed root cause analysis. So challenges are solved superficially, and the root cause of the challenges is not addressed. I'll give an example with the current impact teams that we are implementing, which also have an aspect of the cold chain of the vaccines in some of these areas that we are working in. You realize that the root cause will be perhaps you have low BCG coverage, but if you dive in further, the challenge is the supply chain. It's a cold chain equipment that is broken down, and that is why you're having the low coverage. So they'll focus on addressing issues around coverage, looking at maybe staff attitude, perhaps looking at why the mothers are not coming. Well, the root cause of the challenge is actually supply chain. So for me, I would say it is the ability to do a root cause analysis, the ability to inference the data, the ability to see the data at the different levels or easily access it. Thank you.
Great, thanks, Mercy. And I think in the interest of time, let's move on to the next question. So this is one that's really related to partnerships and their requirement for partnerships in country across a wide variety of partners. And so how have you navigated open data across partners and negotiated transparency and accountability? We talk about country ownership of health systems. So how have you gotten buy-in from the MOH to have visibility into the supply chain? And I assume that's visibility not just for them, but for other partners. Would any of you like to respond to that?
So let me go very quickly. I think it's a very broad question. I think the short answer is the actual owner of this is always the government. So what we've done in Ethiopia is, even though it might be us who provide the support on the system side, we never ever come close to even begin to think about sharing any information without the government's consent. So the process we've been doing is we asked whoever is asking for data to go directly to the government. It's the government itself that actually grants that permission. So I think the quick answer is that there needs to be a broader country level data sharing governance policy, and that is that policy that has to be shared among different partners, international organizations, and so on. So I'll stop there.
Great, thanks so much, Al. So I am going to skip down here while I get a little clarification, hopefully, on one question. So this, again, I think is for Al. I know Ethiopia is working on incorporating global standards into their supply chains. Questions for other countries. Do the government see value in the role of global standards as part of supply chain optimization, which contributes directly to patient safety? So Mercy and Harrison, perhaps, would you be able to respond to that?
Yeah, I'll give it a try. Yes, Tanzania sees the value in global standards, and I think that the government will welcome such investments. And I think to start with, what we are doing within, for instance, the vaccine information management system, we are tracking, at least we are tracking the product from the advanced shipment notice information, and also looking across, like making sure that we are tracking per batch what ends up being used in the immunization session, even in the outreach posts. So I also saw like there was a question on the last mile. So what we are doing is we're making sure that even when we are the healthcare worker is going to extend care to those in the last mile using maybe mobile or outreach interventions, they still are using digital solutions, or even using a paper form that will be later on transferred into the digital platforms. And I think Mercy talked more about the community healthcare worker who also go all the way to the last mile. Thank you.
Great, thanks, Harrison. So Mercy, it looks like there are a couple of questions related to C-Stock in here. Is the software online or offline? Is it a pull or push system, and is it captured for all health facilities in the country?
Thank you. To ensure that these hard-to-reach areas are able to report whenever they come in contact with the internet connectivity, we have it offline. So as soon as they get onto a grid or the internet, the data can be translated onto the dashboards that are visualized also at the national level. On the pull and push, just to remind you that the C-Stock is based on the consumption data, and that the community health volunteer will not have the capacity to understand all the systems. So what happens is that anytime the community health volunteer would require commodities, that is based on their reporting, which is the consumption data, is when they can be resupplied. And if it is an emergency order, C-Stock does have that option of emergency ordering. It has the nags and alerts also on the reporting. So if it's an emergency, their supervisor, who is a community health assistant, will get that. And remember, the supervisor can also view the dashboards and kind of understand what is the stock status of the community health volunteers that he or she is managing, and the reporting rates, or if reporting has been done by that specific community health volunteer. So in the event of an emergency ordering, the community health assistant, who is the supervisor, can quickly inform the volunteer on which community health volunteer to contact for a resupply. That's in the event of positive or a negative adjustment, and also can inform the community health volunteer through, again, the same system, whether they need to come to the facility to pick the drugs if the drugs are available. So it's based on consumption.
Thanks so much, Mercy. And I think we have unfortunately come to the end of our time. Before turning it back to Christina, I just want to thank all of the panelists for your time today. I think it's been a really stimulating discussion. And thank you, Christina and GDHN, for the opportunity to be here today. Over to you.
Great. Thanks so much, Edward. And thank you to our panelists, Mercy, Harrison, and Al. Really appreciate hearing about your experiences, both things that have gone well and things that you had to come up with new solutions for, and really appreciated the focus on the data and instead of just kind of the shiny tool, and really what promotes the use of this data to actually improve supply chain. So I appreciate the discussion today. Judging by the number of questions we received, and I know we weren't able to get to all of them, our audience also really appreciated the conversation. So I just want to thank the team here, Edward and everybody, for putting together this panel. And thank you all for joining us. I did put the link to our listserv in the chat if you would like to join the Global Digital Health Network to get more notifications of our meetings like this. Please do sign up. And I hope everybody has a good rest of your day. Thank you. Bye-bye.
Thank you all.
Bye-bye.
Bye-bye.
Bye.
Thank you and bye.
Bye.